Recording in
Well, good morning, everybody. It's a brand new world after the election, but I'm not going to go there. Okay. For those of you who were yesterday with us over at Mission Bay, it was a great all-day event on stones, and we had a motley group of people giving talks with input from urology, from nephrology, and Ryan C., who came from Nashville. For those of you who don't know Ryan, Ryan is sort of part of our department about 9-10 years ago. Is that right? And he initially was born in Los Angeles, went to that little farm down south called Stanford, and then went down to Loma Linda, and then came to the University of Washington, and then came here, and now is doing amazing things at Nashville, at Vanderbilt. He has, at his age, doing amazing with multiple R01s and a Corey grant. And for those of you yesterday here listening to how this is going to be the new SEER database for urinary stone disease is going to be very exciting as we look 5-10 years down the line. So Ryan's just a dear friend for many of us here in the department, and for me. He's got a loving family, and it's been a really nice couple of days being together. So on behalf of Ben and the department, we've got some goodies for you to take home, along with some of the maps for Madeline, who loves maps. Is one of his two daughters, and we're looking forward to having Ryan's talk today. So thanks for everybody for coming. Ryan.
Thank you, Marshall, and thank you, Dr. Breyer, for the kind invitation. It certainly is an honor to be back. It's amazing how 10 years goes by really fast. So yesterday we talked a lot about how 24-hour urines didn't work really well. So today we're going to talk about how 24-hour urines work. So, and also recognizing that the in-service is coming up, I'll try to highlight some things for the residents.
Doesn't mean it's true, but it's for the in-service.
All right. And so one of the disclosures I do want to make is that I do order a lot of 24-hour urines in my practice. And so I think one of the best parts of being in academic medicine is that we have a clinical hat that we wear, guideline-based, you do what you're supposed to do, but we have a research hat, an academic hat, where we get to explore and question and challenge the dogma. So this is the outline. We'll talk about the role of the 24-hour urine evaluation and management, talk about the debate between the concept of empiric versus selective therapy. And I'll highlight 4 example scenarios where I think 24-hour urine is helpful. I think this is really going to be the practical part of the talk, hopefully for many of you who may not be interested in stone disease as a research field, but maybe will be taking care of patients with stones, and some future directions. So it's important to know for your boards, oral boards, written boards, that you'll get stone questions, and you should expect at least one question on your oral boards related to a stone question. And for the guidelines, we know that 24-hour urines are indicated for any high-risk stone patient, recurrent stone formers, family history, and your patient with a risk factor, or interested first-time stone formers. And the nephrology guidelines are somewhat similar, and the EAU guidelines are very similar. They don't talk about the first-time stone former, but any high-risk stone former, you're going to recommend 24-hour urine testing. So that's the clinical hat that I wear. But the research hat party really wonders why the ACP said this. So the ACP creates the guidelines for primary care physicians. And what they say is that overall, the evidence is insufficient to conclude that having baseline stone composition, baseline 24-hour urine chemistry is necessary before instituting diet and pharmacologic recurrence. And these have real-world implications because this is taken from the Aetna website, which is a large insurance provider in the United States. And what they say is that metabolic environmental profiling for assessing stone risk is experimental investigational. And so I don't know if you've had any patients have any problems with 24-hour urine being covered under their insurance, but I've had some, and this is out there, and this was there a couple years ago, and this was there last, a couple months ago when I checked again. And so what is the evidence supporting 24-hour urine testing? Well, there are 0 randomized trials supporting 24-hour urine testing prior to giving medication. And the trial that is constantly cited in the guidelines is one that was done about 25 years ago among patients with recurrent stone formers. And the one group that got the intervention had pretty regular follow-up. They had 24-hour urine tests, they looked at it, they followed a plan, and then they instituted a diet medication. But the other group basically had them follow up at the end of the study, which is 2 to 3 years, just like, come back later. And then they asked them how they did. So there was really differential follow-up, and there's some really major problems with that study design. Okay, so Marshall, you can't answer this question. So what animal is this? Can anyone guess? We're talking about the creature on the left, not the one on the right. So you say alligator? Yeah, it's a sea lion. Yeah. Okay, so why would you test, right? It's rational that you would want to test somebody, get more information. You know, it's all the information you get from a 24-hour test is objective. You get numbers, and it's quantifiable. You can screen for uncommon conditions. This is, I think, really one of the great reasons to do it. But you don't find a lot of these rare conditions very frequently, but you're going to screen for primary hyperoxaluria. That would inform further genetic testing if their oxalates are really high. The guidelines talk about this threshold of 75 milligrams. So think about that on your written boards. Cystinuria is often screened for these panels. You can look at their serum labs and their 24-hour urine and infer distal RTA, incomplete RTA. And it allows you to take a whole list of possible things you might need to give the patient, diet, medication, and you might just focus on the things that are really wrong with the 24-hour urine. That's helpful. And you can follow these patients with further compliance or adherence to treatment, and you can do follow-up testing to assess for treatment response. And so in a way, this is a biomarker, right? This is the best biomarker and most commonly accepted biomarker we have in clinical practice. I do want to acknowledge that a lot of my interest in this topic really stemmed from early in my training, working with Marshall and him complaining about the 24-hour urine all the time. We decided to write a paper because I actually had to write these ideas down, and this generated this work. And I'll say to the trainees, a lot of the things that you're doing now are laying the groundwork for what you might be doing in 5-10 years. You might not be able to see exactly what will happen to that work, but everything you're doing now has value to that. So what is the real world evidence of use of 24-hour urine testing? One of the challenges is that not many people get tested, and the testing is quite variable. And I think that really communicates that there is an uncertainty of evidence or a lack of good evidence in the field. So there's claims data showing that about 7% of high-risk stone formers get tested. And when you order it, only 50% of people actually do it. And when you have people started on medication, only about 20% of people have follow-up urine testing. So for the residents on the AUA guidelines, when are you supposed to get the follow-up 24-hour urine test?
Yeah, make it no sense.
Yeah, within 6 months. Okay, so it's within 6 months is what the guidelines say. What's the evidence for that? Not great, but that's what's on the guidelines, okay? So, and who gets tested really depends on the specialist and the provider, right? And maybe their comfort level and their expertise. And so I think there's a lot of need to improve the evidence base in this field. One of the things that often people say about 24-hour urine, you tell patients, oh, it's really easy to do. And if you've ever done a 24-hour urine, it's actually quite complicated, doing them myself for research studies. There's a lot of instructions. There's a lot of steps you have to take. And, practically, I call this the 24-hour urine cycle of futility, where you order the kit, they forgot to do it, and then you send another one, and the test, it was inadequate. You ordered again, and they swore they did it, and then patients end up giving up. And you might see that at your VA, or you might see that in your own practice. But I think this is one of the other challenges of 24 urine is like the actual, how do you do it? How do you do it how do you get patients to complete it the right way? And to add on that, we've looked at variation within the Veterans Health Administration data. And what we were able to show is that even though Litholink, for example, is a panel-based test, right? You order the test and you get 20 different things. It includes what the AUA recommends within it, like volume, citrate, pH, creatinine. But within the VA system, if the institutions don't do a send-out lab, when they do the urine test, only about 55% of them have the complete set of analytes. And there's quite a bit of variation across institutions. What you're seeing, each of these lines here is an institution, and this is the adjusted variation by facility level. So just to summarize here, 24-hour urine testing is recommended by most, but not all guidelines. And I think the clinical rationale is strong. It's very testable on exams, but the real-world evidence base needs to be stronger. And I think as a result of that, the real-world use is not as great as it could be. So I show this picture here. I know there were some pictures shown yesterday about the Cystinuria conference. I just want to highlight that Marshall and I do disagree about the logo of these t-shirts, but just to highlight some of the people that have passed through here, and also Dr. Chi, who really has been instrumental in my career as well, mentoring as a mentor for me. So I don't want to highlight now the debate between empiric versus selective therapy. And so when I talk about empiric therapy, what I mean by that is when we give empiric antibiotics, you're giving someone antibiotics without really knowing what bacteria you're treating or what the sensitivities are, right? And when we give people kidney stone prevention, whether that's diet and medication, you have some information, like you might have their age and you might have their history of stone events. You might have some of their stone composition, but for this discussion, empiric therapy means treating them without knowing what their 24-hour urine results would be. And so we have to recognize that we give empiric advice to patients all the time. We're telling people to drink more water without knowing how much urine they make. We tell people to eat less salt without knowing what their urine sodium is, right? We're giving the people, we're already doing this. And presumably even for medications, if you were gonna have a very frequent stone former, why not just give the medication up front without dealing with the weeks and the months that you're gonna do the testing and waiting for the test and calling them back? And why not just give it to them when the patient's most willing to take it? And so what's the evidence to support empiric therapy? Well, there's indirect evidence. If you take all the randomized controlled trials for the medications, thiazide, citrate trials, many of the trials didn't require people to have baseline urine abnormalities. So in other words, you didn't need to know the urine chemistry for some of these patients in these trials to benefit. And so just to list, for example, if you look at the trials that for citrate, some of the trials required people to have low urine citrate, and there are other trials that didn't require them to have low or normal citrate. And that's the same for trials that may or may not have required baseline hypercalciuria. A lot of the thiazide trials didn't require the individuals to have high urine calcium, and there was a benefit in many of those thiazide trials. So we took a look in claims data. This is Optum, which is a private insurance database. We looked at patients with kidney stones receiving medication, and we looked back after that first use of medication within 6 months of whether they had 24-hour urine or not. And so we classified them as empiric versus selective. And we actually found no difference in the rates of subsequent ED visits, hospital admissions, and procedures. And any adverse event here is the cumulative event. So the average treatment effect, what we're seeing is that there's no difference, whether they have a 24-hour urine that preceded medication or not. But we thought, well, maybe there are some subgroups that might benefit. Maybe there's some high-risk groups. And so we looked at UTI and CPT codes for large stones like staghorns, and patients with codes for some of these other conditions like bowel malabsorption, things like that. But the only signal we found actually is that if you looked at patients receiving medication and you look backwards and they had a history of at least 2 or more stone events within 2 years, recurrent stone formers, then there was a signal. So to summarize here, these 2 papers, there might be the average treatment effect might find no difference, but in the group having recurrent stones history, there may be effect. So really all of this, I think, indicates that we really need a randomized trial, right? And so this is one of the things that we're doing. We're almost done accruing for this. We're randomizing patients with recurrent calcium-based stones to empiric diet medication or a selective approach. And as simple as it sounds, it's actually quite complicated to really agree on what's an empiric strategy and what's a selective strategy. So I'm happy to go into more details if people have more questions, but everybody's getting 24-hour urine testing. At 1 month, the selective group has everything adjusted and the counseling changes or gets more personalized. The empiric really gets the same thing. They don't know that, but they can probably figure it out. And then the outcome is going to be supersaturation. We can't look at stone events because they'll take years to form, and then the studies get really expensive and people don't want to fund those. But they're willing to fund this one. So hopefully we'll get some insight into strategy. So if there really is no difference, and we're going to look at this as a superiority and a non-inferiority type analysis. If there really is no difference, or it's maybe even non-inferior, you could argue that that would support empiric therapy as a reasonable option. If selective therapy was really better, then that would actually support the data of use for 24-hour urine. So I think it could, either way, however this comes out, it'll be a contribution. Any questions so far? This is my little daughter playing with her urine kits. Yeah. For this trial, okay. The main exclusion criteria are anybody with a uric acid or any infection stone type history, GFR less than 60, any type of potential secondary cause like primary hyper-PTH, enteric causes, and those are the main. And then also if they're currently on a stone prevention medication, they can't be part of it. Okay, so we'll talk about some 4 example scenarios where 24-hour urines are helpful. I'll try to highlight the parts that are actually testable. And then all the other ones, I think we can debate, but I think this is where I think there's a role, okay? So we knocked down supersaturation yesterday, but I do think since our paper came out, Marshall, I think there have been 2 papers that have been supporting supersaturation. And I think in my clinical hat, I do use it. So the first one is a Prochaska paper. This is looking at the health professional follow-up study in Nurses Health 1, Nurses Health 2. So basically healthy patients without kidney stones, primarily health professionals. They followed them over time and they did 24-hour urines on them. And then they followed them over time, and some people made an incident stone, their first stone, and some people didn't. And they looked at their baseline supersaturation. And as you would expect, as the supersaturation went higher, their odds of having a incident stone goes up. And you would think we would have the evidence for that, but this is the first time that we have. And this is also true for calcium oxalate stones, or also calcium phosphate supersaturation and uric acid supersaturation. But what about recurrent stone formers? So this was a secondary analysis of the Orgy diet trial. So it's old literature, but they had 5 years of follow-up for these patients. And what they were able to show is that if the baseline supersaturation was higher, and they looked at relative supersaturation, and equal2 is the equation, is the calculation of they're different calculations of supersaturation. Equal2 is the one that Litholink uses. So for every unit of increase of the relative supersaturation, there was an 8% increased hazards of a subsequent stone event. And this is a composite radiographic and symptomatic stone outcome. Okay, so this is the evidence, and it's the direction that you would expect. It's not the biggest difference, and it's not the tightest confidence interval, but it's there. So how do I use this clinically? Well, remember, these two studies looked at relative supersaturation. Litholink, because I know we all use that here, reports supersaturation. So relative is calculated by dividing what the normal population supersaturation is supposed to be. It's around 3.3. So if you take some of these older studies and you multiply each of these numbers by 3 to 3.3, that's what you're going to see on the Litholink report. So the first category is anybody with 3 or less. And then you have 3 to 6 and a 6 to 9 example. And so for this, the difference is 3. And that's what I use. And so for this is a fake report that they had online. But you have someone who went from 11.9 to 8 to 5. So each of these gaps, I can tell patients now that it's a meaningful change. For calcium phosphate, the difference is about 1. So that's where the meaningful difference is. Again, this is all extrapolated data, okay? But this is, I think, helpful, especially when the values go up and down. You're not quite sure which one's helping or not.
These are the supersaturation calcium phosphate went down, but the one for calcium phosphate went up.
Yeah.
I'm just curious.
We'll talk about that. Yeah. Oh, the calcium phosphate from the first to the second one went up a little bit, and it went down. Yeah. Okay, so scenario number 2, I think, is what's the evidence for the utility of follow-up testing after treatment? And so I think I'm gonna take a trial that we all were really shocked about and then kind of put it on its head. Okay, so this is the DEA trial. We're all familiar with this one. Okay, this is not going to be on your boards because it's too new and people are still trying to understand what it means. But this was a Swiss study, recurrent calcium stone formers, 4 arms, placebo, 12.5 of hydrochlorothiazide, 25, 50. Okay, it was once a day dosing. And they looked at the outcome of radiographic or symptomatic stenosis. So it was a composite outcome. There was no difference by a follow-up of around 2.5 years. Okay, so what were some of the problems of this study? Well, one of the things to zero in on is what do we think thiazides do? Thiazides, well, let me ask you, what do you think thiazides do? Any resident? What's the primary action of thiazides in relation to stone formation? Yeah, in the thick ascending limb. Perfect. So it's primarily about urinary calcium, right? So let's look at the urinary calcium in the study. And so each of the rows here is the different groups. And then you have the baseline and you have the follow group. And you can see that the milligram decrease, milligram reduction is about 30 milligrams on average mean. So the question is that enough? Because the historic trials of thiazides, they drop by a lot more than that, okay? And there were problems, other things, the urine sodiums went up over time. The adherence rates weren't really that great, and a lot of them were self-reported. And so that might partially explain the calcium, lack of calcium change. But this has been really the fundamental question, is this urine calcium change sufficient? So what we did was we looked at a data set of Medicare patients with Medicare's patients with link to Litholink data. And we took their urine calciums before and after starting a thiazide. So they had to have 2 24-hour urines, and in between they had to have 24-hour urine calcium. And we also looked at the adjusted change in urine calcium for age, sex, different parameters, including medication adherence. And what we found is that if you and we looked at thiazide dose, but overall you could see that on the y-axis, the urine calcium change was about 80 to 100 in the Medicare Litholink cohort. And as the dose goes up, you're going to have greater and greater amounts of urine calcium change. And just to note that the highest group is the 50 milligram a day, includes a 50 milligram a day hydrochlorothiazide group. What I put in red are the changes that they saw in that trial. So this, this helps potentially explain the results of the study, and that maybe a lot of the patients weren't taking the thiazide like they were supposed to. And what we also did with this study was that we took the change in urine calcium, we divided the change in urine calcium into tertiles, and we followed these patients over time. And now we're looking at harder outcomes, claims-based outcomes of surgery, ED visit, hospitalization, not just radiographic stone recurrence that other study looked. And what you see is that in the gold and the blue bars, their probability of subsequent recurrence is a lot lower than the group that had very minimal urine calcium change. Okay, so this adds further evidence that I think calcium change is important. And the implication here is that if you put someone on thiazide, it's probably a good idea to check a follow-up 24-hour urine to make sure that the urine calcium drops by at least 80, 90, 100 milligrams per day, so you can actually make a difference in them. And this is probably not testable on your written or board exams, but just remember that the effect of thiazide is really dependent on urine sodium excretion. So if these people aren't really keeping their salt intakes down like they don't in Tennessee, then the thiazide really isn't going to work. Okay, scenario number 3. This is a problem that really annoys a lot of us in the field managing 24 hours. What do you do about the patient with this? So let's just say this is a recurrent stone former. They have mildly to elevated urine pH. Their citrate's low, and you're like, do I give them potassium citrate? And what's the concern? Well, if you give them potassium citrate, this study here was a placebo-controlled trial of calcium phosphate stone formers. What happens to them? Well, the citrate goes up in B. That's good. But on C, their pH also goes up. And then the supersaturation gets worse. It went up, so the higher is worse. So are we hurting people by giving them potassium citrate if their pH is high, but their citrate's low? This could be on your boards where you get a scenario where someone is making calcium oxalate stones and you put them on potassium citrate, and on the test question, they gotta give you the follow-up urine pH. It's gonna be high. It's gonna be like 6.8, 6.9. Then your answer is they converted to calcium phosphate stones. Okay, so I've seen that test question before. And so we kind of looked at this a little differently. We said, well, what if you give them a thiazide instead? And so, observational data, we found 107 patients with this abnormality started on a thiazide, and then about 1,200 patients started on potassium citrate. We followed them over time, and we've actually found that there was a improvement, or there was a less hazards of a stone event if you give them a thiazide. And we also controlled for, we did also account for baseline citrate and calcium as well in a sensitivity analysis. So this is actually a controversy in the field. I think there are people who would give them thiazides. This group, thiazides, there are a lot of people who give potassium citrate, but I think this calls for more study. But it is thought-provoking. Any questions? Yeah. For this study? So this one, we didn't require a follow-up 24-hour urine. So. All right, this is more for Marshall. Marshall, do you know where this was? 10 seconds. Hint, it's underground. It's not in the US. London. Yeah, London. Yeah, it's good. Okay. I was gonna test Tom, but huh? We were eating. It was a great Indian restaurant. I forgot the name, but it's the famous one. They had to wait in the line. Remember that? Okay. Yeah, that one. Yeah, you guys all been over it. Okay. Yeah. Scenario number 3. This is where I think I earned my CME credit here. So, well, I think giving you guys a little bit of insight here, I think will help. And I think some of you may already know this topic, but I think looking at the second row of the 24-hour urine, can really give you some insight into the first line, point for urine. Okay, the second row is where we kind of ignore things. So I'm really going to focus on these three parts: the pH, the ammonium, and the sulfate. Okay, and when I start going to the second line, everybody goes like, "Oh my gosh, I never looked there." Okay, so just a little background here. Why do we care about urinary ammonium? That's a component of stones. Okay, magnesium ammonium phosphate, ammonium acid urate stones. They're not that common, but it's in the urine, and it matters. And then it provides about 2/3 of the daily acid excretion. So your body gets rid of acid through breathing and through the urine, right? And so, and you have titratable acid. So there's this concept of net acid excretion, which is comprised of ammonium, titratable acid, also subtracting bicarbonate, but bicarbonate in urine is very, very little. So these are the reasons that people can have low urinary ammonium. You can have inhibited ammoniogenesis. We talked a little bit about this yesterday in the group, is that metabolic syndrome, insulin resistance, or CKD can impair your body's ability to get rid of acid. This is why you have those large patients making uric acid stones and their pH is low, because they can't get rid of the acid in ammonium form. And diet, if you eat a very high alkaline diet, if you're a vegan, vegetarian, you're giving more of an alkali load, you're not going to want to excrete acid. So that makes sense. And then also, if you take more alkali, if I give you sodium bicarbonate or potassium citrate, your body's not going to need to make ammonium and excrete ammonium. So that makes sense. What are the reasons for high ammonium? You can have loss of alkali from your body. And the most common way you do that is through GI losses, short gut, malabsorption, diarrhea. Those scenarios, you'll lose the alkali in your body, but your urine has to your kidneys have to compensate. So they do that by getting rid of the acid through ammonium. If you eat a very, very high protein diet, specifically animal protein, you're gonna have more of an acid load. So your body's gonna get rid of that through ammonium. And then you can also have an inappropriate rise in the urinary ammonium from urease organisms. So urea gets cleaved into ammonium, okay? So sulfate is one of the things that can help us tease this out, because sulfate is a specific marker of dietary acid load. So sulfur is preferentially enriched in meats, right? It's the amino acids, the methionines and related with the sulfur group. So if you can kind of remember this, is that the difference between the ammonium and the sulfate should be about 10 to 15 plus or minus. That kind of is one of the takeaways, is that really the ammonium sulfate, they kind of go together. And if you have one that's really high or low and you have a big difference, that could give you some insight into what's going on. So I'll go into this a little bit more, but I'm just going to go into a couple cases here, okay? So just to kind of show you again, if I plot the pH, urinary pH on the left side, and you have the ammonium sulfate difference on the bottom. So on the left, you have someone with eating a lot of alkali, their ammonium is suppressed, right? So the NH4SO4 is low. You can see this, right? So this is going to be high. Someone who have impaired ammonia excretion is going to have low ammonium, right? This is going to be low, and the pH is going to be low. The RTA, you're going to probably figure that a lot of that's where you have the high pH, low citrate, and they're going to kind of be in this middle area, right? And the distal RTA, the reason why that's here is because they have impaired ammoniogenesis, right? They can't secrete the acid. That's why they're there, okay? And then the urease activity, that's the one where that's testable, where you're going to have someone with very high urinary ammonium that's inappropriate because the pH is too high, right? And then this is the GI alkali loss. The ammonium should be high, driving this up, okay? And the pH is going to be low. Okay, so let's go through some cases here. And what you're going to do is you're going to focus on the pH, then you're going to look at the ammonium and the sulfate. So this is just a diagram that we just went over. So I'll go through some cases. So this is case one. These are real patients. The serum labs are shown on the left. The potassium's replete, and they're not on medications. So Does anyone want to try to explain what's going on? Okay, yeah. Right. So in this case, what you're seeing is that the pH is low, and then you look at the ammonium to the sulfate, and that there's a big gap. The ammonium is much higher than the sulfate. So this person's excreting a lot of titratable acid, right? So or excreting acid through ammonium. And so this person has GI losses. Okay. And you look at their history, yeah, a lot of bowel resections, and they're having diarrhea. And that, so when you ask patients like, are you having diarrhea? A lot of them you're not, yeah, no. But this is actually, you have the data to say, sometimes I walk in the room, it's like, hey, are you having quite a bit of diarrhea? And they're like, oh yeah, they've been having some IBS or some really active IBS. So it doesn't really necessarily change the management. You can give them potassium citrate probably, right? But it gives you some insight into the chemistry. Okay, case number 2. Again, another real patient. Anybody want to guess what's going on? All right, just focus on those 3 numbers. Don't look at the other numbers. The pH is low, but the ammonium relative, the ammonium kind of looks suppressed relative to the sulfate, right? This patient has metabolic syndrome, right? Does he have impaired ammoniogenesis? Is not secreting the ammonium that they should be, and BMI is 47. So again, it gives you some insight into what you're seeing. I think I have just 2 more cases. The case number 3. Anybody want to guess what this one is? Urease inhibitor. Okay, yeah. So first of all, I mean, a pH of 8.5, that's not physiologic. No human can make a urine like that normally. So, and then you kind of look at the ammonium relative. There's a ton of ammonia production here. This is not normal. It's not physiologic. There's something in there. And so this patient has suprapubic tube, they have recurrent UTIs, right? And so this is helpful, especially if you're monitoring someone with a history of infection stones. The oxalate, we also recognize those from tube feeds and things like that. So we worked on that. I'll just go through this one really quickly. So this patient has a high pH, has a history of calcium phosphate stones. What you see is that the ammonium is suppressed relative to sulfate. So this person, I don't have the history for this one, but this person is either eating on a very, very alkaline diet, or they're on medication like sodium bicarbonate. And the reason why it's probably sodium bicarbonate is that there's a difference between the calcium, the sodium, and the chloride. So it's probably not all from salt. There's probably some sodium-based alkali. Okay. The other thing to mention is that you want to make sure patients are potassium replete, because if their potassium is low, then the ammonium will drive ammonium excretion. Okay. Any questions so far? This is when Marshall visited as a visiting professor earlier this month. Okay, now that your brains are full, I'll just talk about some future directions. So I think, if you're ever thinking about where to make a niche in academic medicine, or where the knowledge gaps are, look to the systematic reviews, because people are doing that work for you to identify the research needs. And so this is 2024 systematic review, AHRQ systematic review. And I just want to highlight here that among the 4 key questions that they're proposing, that the work isn't done yet, but this is publicly available. The 4 key questions, many of them center on the effectiveness of diet and medication based on baseline 24 urines, and whether baseline 24 urines predict recurrence. So this is an active area, and there's a need for this. One of the projects that I do want to highlight, that we talked a little bit about yesterday, is that hopefully, Marshall mentioned about the SEER Medicare data for stones, but we have the opportunity here as a community to build a research resource the community. So this is one of the projects that we're working on. We're building a cohort of over 200,000 patients with kidney stone disease based on PCORNet data from 9 different centers across the US. We're going to include structured data and 24-hour urine and stone data, and we're going to add extracted data from CT images and notes, and then we're going to focus on an AIM-3, disseminate this to the community. We just got started a couple months ago. The work is getting people to all believe in the same vision, and I have to credit Greg Tajan, who was a former resident here and is my co-conspirator on this. Or dual PIs on this. But these are the sites that are involved: the STAR Clinical Research Network and PSNet Clinical Research Network, and we have additional collaborating sites at UPenn, Mayo, and University of Wisconsin. And so this is the overall diagram of what we want to do. We're going to extract the data, harmonize it, add it with 24-hour urine and stone data, and we probably have about 300,000 CT scans to extract data from a lot of the keynotes in their records. We're going to use NLP and machine learning methods to pull data out. And we talked about some of those methods yesterday. And then one of the key challenges but opportunities, we're going to figure out how to disseminate it to the research community. We're going to make it available to people here. These are our dissemination strategies. Chuck Scales at Duke is leading this work group, and give him a lot of credit for his experience and vision on this. But this will include public access portal, web-based portal. We'll do pilot grants, we'll do coaching clinics, and we'll have a focus on sustainability and long-term storage after the grant period. So hopefully this resource and other studies that we're doing will give us more insight into how we can modify recurrence, how we can improve our understanding of how best to manage our patients with stone disease. Thank you.